This topic is going to ask you to confront your own fears and anxiety about death and dying. Those of you who are new to the healthcare field may have more difficulty, and I want to try to make this a little bit easier for you when you face your own fears and your own personal hang-ups. Death anxiety. Death anxiety is a primordial source of anxiety. We all have it deep within us. Most of us convert it to something less threatening by denial or transference. One person may choose to believe in their own specialness, that they're bulletproof. Another may believe in an ultimate rescuer. We all prefer not to think about death, for us, for our families, and for our patients. And yet we have to. Let's think for a moment what happens when someone gets a bad diagnosis. When that individual receives a terminal prognosis, their world is changed. It is as if they suddenly face a brick wall which blocks their life's journey. And learning more about our deeply embedded fear and anxiety about death, our specialness, and our not just yet attitude about our own death can help us make better decisions as we travel through that jungle of conflicting emotions that result from loss and the anticipatory grief felt by the dying. Anticipatory grief. Grief that the family, friends, co-workers of a dying individual experience this sadness and a cascade of emotions that is anticipatory grief. It's important to realize that the dying individual also has anticipatory grief and needs emotional and spiritual support from everyone caring about and caring for that dying person. The person who is dying or will die soon leaves the world of the living and enters the world of the dying, which is a world of near-death awareness, NDA. This is a world that we don't know. NDA includes reviewing one's life in its entirety, asking what contributions one has made in life, and strangely being visited, it seems, by dead relatives. It is still undecided whether this is a hallucinatory event or something more spiritual. Two nurses, Maggie Callanan and Pat Kelly, wrote Final Gifts, Understanding the Special Awareness Needs and Communications of the Dying. Again, one of the gifts, one of the books that we've given to families to help them understand what is going on in this new situation for the patient who will die. So, how do we confront the reality of death? Dr. Elizabeth Kubler-Ross, in the late 60s, did an extensive study interviewing patients who had been given bad news. And she wrote extensively about the 5 stages that patients go through. They don't necessarily come in this order, but they include denial, anger, bargaining, depression, and finally acceptance. The reality of death includes the loss of control, loss of functions, decisions, dignity. It causes someone to reflect and say, what have I made of my life? How do I want to be remembered? And for goodness sake, heal relationships with family and friends before it's too late. What ways are they to die? Sudden death, no time for the person to suffer or to go through an emotional reaction. It's so sudden. the steady decline and short terminal phase, such as one gets with a cancer diagnosis or with an advanced life-threatening disease like ALS. And then finally, the slow decline, periodic crises, and then finally a sudden death due to organ failure and frailty. Lung, heart, brain, kidney, liver, all of these are much more difficult because you certainly can't predict well when someone with this slow decline is going to die. So how do you want to die? What experiences have you had witnessing death? Have you had any education about dying and death? Have you been present at what we call a good death, but is really a natural death, a normal death? Have you been present at one? Have you been present at a bad death being one with a lot of suffering and pain or shortness of breath or delirium, seizures, and much more difficult? And do you have a living will or a healthcare power of attorney? Is it time? Probably so. It's necessary to think about your own death, even though you think that death is what happens to somebody else. And it will take you some time with the experience of being around dying and deathing until you get comfortable. So, end of life in America today, there are only a few cures. You live much longer with chronic illness, and the dying process is also prolonged. You think that you're curing disease, that you're preventing death, and all these are good goals, but in the long run, if you practice long enough, your patients will die off. And it makes you understand what your role has been. It helps to contrast what is a normal, natural, or good death with one that is bad. The usual road where the patient becomes bedridden, is more sleepy, lethargic, finally obtunded, and semi-conscious, comatose, and dies peacefully without undue suffering and symptoms. The difficult road is harder. Restless, confused, tremulous, hallucinations, delirium, seizures, and then on to semi-comatose, comatose, and death. Being able to describe these, being able to help them understand that what you will do will tend to make things better and make the death more peaceful, and incorporate them on your team. It's much easier if they understand that you are there to help them and that you have information that can be very helpful to that patient. Teach the family what to look for when death is imminent. Rattling, noisy breathing, cold extremities, skin mottling, patient unarousable, irregular breathing, and then finally agonal breathing where they're gasping. And you want to let the families know early of change. Keep them informed. You will be asked, tell me, how long does Mama have? And I say that it's best for me to describe this in terms of minutes, hours, days, weeks, months. And I do not try to prognosticate directly. I will tell them that it's not minutes, it's not hours, it might be a couple of weeks. I will know more in 3 or 4 days. Let's keep posted so that we know what's going on as it's going on. Physicians who prognosticate are only right about 15% of the time. Let's talk a little bit about guilt and blame. Doctors feel this. Doctors could say, and I have, could we have done something better? Did we do enough? Have we learned something from this particular patient? Families are likely to say, Mama will die because we withheld or withdrew treatment. And nurses, I'm afraid I'll be blamed if this person dies on my shift, or if I give the last dose of morphine. Heard that more than once. And the patient, who of course says, I neglected my health and now it's too late. So everybody is going to feel badly, but it's necessary to try to understand this is part of a natural part of living. And at the end, hopefully, be able to share these words. I love you. Please forgive me. I forgive you. Goodbye. And then comes grief and bereavement for the family. It's better to deal with the loss of any kind. You have to accept the reality of the loss. You have to experience the pain caused by the loss. And finally, you adjust to the new environment after the loss and slowly rebuild a new life. Don't expect grief to go away completely. Grief is the price we pay for loving. I don't know who wrote that, but I love it. I think it is so true. Grief is the price we pay for loving. So it takes time and experience to become comfortable dealing with death and dying. The more involved you are in the process, the easier it becomes. You become a humanist as well as a scientist, a friend and a comforter, what a healthcare professional should be for the dying patient. Thank you.